You can send it right.
A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side.
So, good morning, good afternoon, good evening, friends, depending upon which part of the world you are joining us from. So we welcome you on behalf of CAHO. I'm Dr. Vijay Agarwal, the president of CAHO, welcoming you to this another episode of the ISQua CAHO webinar, which is on resilience in healthcare. And to moderate this session today, we have Dr. KP Pichumani, who is a very well-known name in our CAHO circle. He is the managing director of the Sri Ranga Hospital in Chengalpat, and which is a kind of a small town near Chennai. And as I was just saying a few minutes back, to me, he is like an epitome of resilience, because a person like him who has from that small hospital, how they have worked towards making a name in terms of patient safety and quality all across, not only in the country, but even outside the country. And therefore, this session today is going to be a very interesting one, because I feel that out of the various attributes, it is the resilience which is going to take us forward. So to introduce Professor Ross and Professor Cecile, I will ask Dr. Pichumani to please do the honors. Over to you, Dr. Pichumani.
Thank you very much, sir, for the nice words. At the outset, I would like to thank Dr. Vijay Agarwal, President CAHO, and Dr. Lalu Joseph, Madam, Secretary General CAHOs. Sir, actually, today's topic is very nice, and it's wonderful. And I could see two eminent speakers from the Scandinavian countries, Sweden and Norway, visiting us on this particular topic. And of course, resilience is so essential, considering the present scenario. Post-COVID, we got a lot of challenges also. It actually brings in enormous pressure on the burnout on the healthcare professionals. And definitely, we are going to hear from two top people who are all going to talk about the resilience in a big way. So let me, I'm very proud to introduce the first speaker, Mr. Axel Ross, Dr. Axel Ross, who's got a vast experience in as a clinician surgeon, served for 35 years in Sweden, and of course in healthcare as a surgeon and several other capacities also. And he was a true leader and researcher in patient safety and quality in healthcare. And is also presently a member in ISQua Academy and a board member of the Resilience Healthcare Society from Sweden. So we're going to hear a lot from Dr. Axel Ross, and he's the right person to talk about this particular topic of resilience in healthcare. Of course, I'm going to introduce the second speaker also, who is Cecilie. I was told that I should introduce her as a Cecilie, because she is an excellent person in the field of healthcare, resilience in healthcare. She's a nurse by qualification, and she's now an associate professor at SHARE, the Center for Resilience in Healthcare at the University of Stavanger, Norway. And she's the right person to be here in this particular place because she has got enormous contributions towards resilience in healthcare, doing a lot of research. And with these few words, I'm very happy to introduce both. And actually, with these few words, I hand over the mic to Dr. Professor Axel Ross, who is going to be the first speaker today. Thank you very much, sir. Please begin.
Thank you, Dr. Picciomani and Dr. Agarwal. It's very nice for me and Cecilie to be with you this year as well, as we really enjoyed the session last year. So we were happy when you got the invitation to be here together with you today. I will start out. I'm sitting here in my office in Jönköping, which is in the southern part of Sweden. It's a warm late summer day. It's rainy, but it is a pleasant day still. Can you now see my screen?
Yes, we can.
Yeah.
Good.
So I will start and Cecilie will follow. And these
you
are
can
then
make it full screen if possible, sir.
Isn't it full screen now? I thought it was.
Yes, your presentation slide. So
okay.
Yeah. Even
I'll try it again. Should be right.
Not yet.
Is it still not right?
Still.
Bytte oppe på bildskjerminnstillinger, Axel. Så bytter du bare skjerm der, ja. Og så trykker du växla eller...
Växla kanske? Is this better?
Yeah. Yes.
Yeah.
Thank you. And our joint team, Norwegian, Indian, Swedish team, were then resilient to my misuse of the machine. So what I will do is that I will start with do a brief recap of what I talked about last year. And then I'll cover something that's nowadays called systemic potentials management, but which was formerly referred to as resilience assessment grid. The thing here is that, as you all know and are aware of, that modern healthcare systems are complex. And when we think about safety and want to be safe in modern healthcare, we have to address that complexity. And with complexity, of course, we understand that there will always be changes, disturbances, challenges, and also opportunities to improve. Resilience has been described and defined as a resilient a system that can adjust its functioning prior to, during, or following events, and thereby sustain required operations under both expected and unexpected conditions. And this was the original definition by Eric Holnagel, which is 10 years old now, but it's still valid. Siri Wiig, and together with others, then defined resilient healthcare as a healthcare system's capacity to adapt to challenges and change it at different systems levels to maintain high quality care. And what Siri and colleagues then really added is that even though healthcare is created at the point where healthcare staff meets the patients, it also depends on how we as a system manages to support what's happening in the front line. So resilience really takes place on all levels in a healthcare organization. If we combine my previous slide with this one, we see that safety in healthcare has to be related to resilience in healthcare. So what is then the focus of resilience? Well, resilience is an expression of how people, groups, organizations, those things that we have in a system, how they cope with everyday situations, how they manage to get through an ordinary workday with all those things that might happen in that workday. And they do so by adjusting their performance to the actual conditions. So then we understand that resilience is something that's done. It's what the system does. It's what the people, the groups in that system does to manage. In the literature on resilience, it's been said that resilient performance requires that an organization has the potentials to respond, to monitor, to anticipate, and to learn. And I will, as I did last year, provide a simple example from reality that can give you an insight into what these 4 potentials are. I will shortly and briefly say something about how we manage an outbreak of ESBL producing Klebsiella in our neonatal intensive care unit at the hospital where I work in Jönköping, Sweden. This is a medium-sized hospital. At NICU, we have 16 beds. This outbreak now happened. I'm still sort of so amazed that time passes so fast. It happened 10 years ago now. 5 children were infected with the bacteria. No one of them developed invasive disease, but we still found this very important and dangerous. After the outbreak, we studied what we had done during the outbreak. And in that study, we found things done that we then categorized according to the 4 potentials of resilience. So I will, by talking about our findings, give you an insight into what these potentials are. If a system has resilience or wants to have resilient capacity, it's demanded that the system can actually respond to threats and possibilities. And in our study on what happened during this outbreak, we found many examples of that. We found that in the activities in the outbreak group, that's a group that was designed to manage the outbreak. And they worked both according to general guidelines that had been developed before to manage a situation like this, but they also adjusted what they did according to the actual situation of the outbreak. So that's on a sort of management level. But we also saw examples of responding on the staff level, how they managed through their daily work. And they did that with this kind of citations that I provide here. We did what we were told to do, and sometimes even more. Sometimes they found the decisions from the outbreak group and management unclear or difficult to adhere to, but then they sort of managed anyway. So we found descriptions of how they responded in the outbreak. The second potential is the potential to monitor. And it says that, to have a resilient capacity, the system has to be able to monitor what is happening, both external of the, in this case, the unit, and also internal in the unit. And we saw that for example, in how they did cultures on bacteria from different places at the unit, at the patients. We saw how they developed a new way of keeping a list of bed occupancy to be able to follow the transmit of the bacteria between patients. We saw how they kept an updated list of available beds at other similar departments around Sweden if they should have been, if it would have been necessary to transport patients to another hospital. So they monitored things to be able to respond. The third potential is then the potential to anticipate. And resilient capacity then demands that the system can anticipate short and long-term changes in both demand and resources. We saw that both on the outbreak group level and on staff level, illustrated by citations like, if these cultures turn out positive, we will. They sort of imagined beforehand what might happen so that they were prepared to act when or if that happened. And also, as you may be aware of, most or at least a high proportion of patients at the NICU stay there for a long time. So there's this kind of sort of relations built up between the families and the healthcare staff. And that was also something that they sort of managed or thought about on the staff level as part of how they anticipated what they were going to do. And last, and maybe not least important, is the potential to learn. We have to learn from everything that happens. We have to learn from how we respond, how we monitor, how we anticipate. And we saw lots of examples of that, both on the management level and on the staff level. So they adjusted along the way during the outbreak. They adjusted how they had staff meetings to be able to learn from each other and to learn from what had happened. They learned lots about the risks. They developed their understanding of the risks. They learned that from what happened during the outbreak. And new procedures thought to be safer was discarded by the staff since they found these new procedures unpractical or unsafe in reality. The difference between work as imagined from the management level in relation to work as done, what was done by the staff. So this was just a very short and brief description of what we found about the management of an outbreak at the NICU, to say something to you about what the 4 potentials are. But what I'm really going to talk about today is how we can measure and improve resilience. And this, of course, has been described by Professor Erik Holnagel. Erik is a senior professor. He's Danish. Some of you have heard about him, read his books, and so forth. He really was among those who developed the concept of resilience engineering, and resilient healthcare. And Erik, more than 10 years ago, also described the resilience assessment grid. But in the last years, he has referred to that as the systemic potentials management, how we can work to manage the potentials of resilience. Erik, as I am, likes to sail sailboats. So when we have discussed this, we have said that managing safety is like navigating, like if you're on a boat and you want to navigate between islands on the sea. You need to know something about the position, where we are now, or how are we doing now. We have to decide what the goal is. Where do we want to be? And how do we know when we are there? And of course, we also have to have controls and processes, these as the tools that we need to navigate from the red cross to the yellow cross. How do we get there? How can we change speed and directions? And to be able to do all this, we of course need to have some kind of evaluation. We need some kind of measurements. But healthcare is provided or done by an organization. So how can we measure what's going on in an organization? In comparison with technical systems that are designed and built, and you know the components and you can measure how they are doing, it's not that easy in organizations. They are not sort of constructed or built. Actually, we don't really know how organizations function. We have some kind of image of how we are organized, but what's really going on is difficult for us to understand and describe. So it's then very much, it's so much harder to define any meaningful measures. And it's also important to understand and remember that resilience is something that's done. It's not a property. It's not something that an organization or a system has. It's more like a quality or a description of how the organization manages and how the persons within it manages, how we perform our tasks so that the organization can fulfill its goals. So resilience is something a system does. And it's then not meaningful to refer to any level or grade of resilience, but we need a way to describe how well we do in relation to what we are intended to do. And this is the sort of theoretical or maybe philosophical background to the development of the systemic potentials management, formerly referred to the resilient assessment grid. This is a model or a method that contains 4 sets of questions, 1 set per potential. And they are used to show position, goal, and also support interventions. The questions are specific. They are meant to point to problems that are important for the organization. They are diagnostic. They should point to details that are meaningful to evaluate so that you can change. And they are also formative. These answers can be used to support decisions on how to improve the potential. And they should be designed so that they truly align to the goal you are aiming for. The method describes generic questions, but these questions have to be adapted to your own workplace, organization, your context. And there are several ways to do that. And these are nicely described in an article by Mariam Safi and co-workers published a couple of years ago, where you can read about the background of SPM, how it's done, and how it has been done in different contexts. So what we want to do is we want to assess what a system does. And in this way, assess the potentials for resilience. So when it comes to responding, to be able to respond, we are assessing how well prepared we are, what kind of thresholds we have for reaction, what resources we have for when we are responding. When it comes to monitoring, we should decide what indicators we need, what kind of delays in communication there can be between when something happens to when we react, and also in what way we can interpret what's happening. The question should, when it comes to anticipating, address what kind of models we have to do that. Are we working on a long or short time horizon, or do we need to work on all? And what kind of risks we are looking for. And when it comes to learning, the questions should support and evaluate how we learn from both successes and failures, and also if the learning is continuous or event-based. That is, if we are learning all the time, if we have mechanisms for that, or if we only learn when something disastrous or something similar like that has happened. And again, I will provide you with an example from pediatrics here in Jönköping, Sweden, where this method was used as means for an improvement project, where they aimed to improve their the resilience they have at that department. This was done in several steps, and also in this paper, when you read it, you will see that most places that have used the systemic potentials management model, they have done that working in several steps. They had a project group to lead the work. They started off with a study, where in the study they, as a findings, described what kind of expressions of resilience they saw at that ward. And then the project group, developed their first version of the questions, the local adaptation of the generic questions. And they had them in the questionnaires and post them to the staff, and did that in some rounds to finally come up with a definite version of the questionnaire. And these are then, I don't really have time to go into all details, but this is then the generic questions that have been published in books by Erik Holnagel, where you can see, and they have been developed by Professor Erik Holnagel together with other joint researchers. And this is what you start with, and this is what they ended up with, their set of questions for the potential to respond. And in the questionnaires, they answered on a Likert scale from 1 to 5 that they did not agree at all, or they fully agreed to these really not questions, but statements. At our unit, we are aware that unexpected events may occur. So they answered that question on the scale from 1 to 5, and in that sense sort of got a knowledge about the preparedness to respond. And you can see all these other questions that they developed. So then, with these questions on this set and other questions on the 3 other sets, you build your own SPM or RAG, and you can use it as a tool for management. You can't measure, or you shouldn't measure only one time. You should measure several times over time. And you should do that as a way to develop or improve your work. Since they are context specific, you can't use this to compare yourself to someone else. You have the aim is to compare with yourself as a support for improvement. So you do that over time. And they did that at this ward, and I just give you an example. They did one measurement, if you call them that, in March, and then in October the same year. And the yellow is the March, and the red is October. And this really not any big changes here. The result is displayed on this spider diagram. But this is then, the results then is then something that you can use for your improvement work, and you can have that as something that you discuss between management and staff. So this was a very, very brief introduction to how you work with the systemic potentials management. As I said, it was developed like 15 years ago or so. There are descriptions from many other industries, not only healthcare. In healthcare, the experience is sparse, I have to say. Only small scale tests, not used for an entire organization. For us resilience believers, SPM-RAG is very attractive, but we have to be honest, say that we have difficulty gaining traction in a world where management and governance are largely based on concrete performance measures and comparisons with others. But India is a very big country. So if we get some sort of Indian experiences and studies on RAG, that would be lovely. I'll end with some tips for reading about systemic potentials management, resilience assessment grid. And that's my final slide. Thank you.
Thank you very much, Dr. Ross. It's fantastic, nice to hear your the real resilience, how to measure it. The first time I'm hearing resilience can be measured. In fact, we don't do that in India quite often. As rightly said, it's such a big country, and it's highly it's highly context oriented, and we have to, I think, develop one set things. And I think the CAHO, by its sheer tentacles of robust methodology, they might come out with a measuring tool. I think Professor Agarwal sir, Vijay Agarwal sir might be able to do that. We all will sit, and as you rightly pointed out, we'll come out with in short time about this.
Good to know. Interesting. Thank you.
Thank you very much, sir. And shall we have the questions at the end of the lecture?
Yes. Yes, Dr. Pachamani, I think let's go ahead with Professor Cecilie.
Yeah, please. So, over to Cecilie, Dr. Cecilie.
Hey, thank you very much. So this was Axel giving you an introduction to what resilience in healthcare is about. And last time me and Axel were here talking to you for a year ago, we talked about how the healthcare profession in general are struggling to attract and keep healthcare personnel. So I wanted to address that today by saying something in my headline about why organization resilience is the key to attract and maintain healthcare personnel. Some of the problem worldwide, and I'm mostly doing my studies and work here in Europe and in Norway, but all over Europe, but I don't think it's that different to what you're experiencing in India. So we know that there is a lack of labor shortages. We have a lack of qualified healthcare workers, and there is a major mismatch between capacity and demand and what we need to do. So while the number of tasks are rising and the number of personnel is shrinking. And this, I think, is the case for all over the world, and we see that it is going to be even worse in the future. So why is resilience and organizational resilience important? This situation is causing stress, burnout, reduced mental health and well-being among the healthcare workers, leaders, and informal caregivers. We believe that the solution of improving service quality and ensuring patient safety begins with creating the right conditions for staff to perform their work effectively and sustainably. So when healthcare professionals operate within organizations that are well equipped to handle everyday challenges and unexpected changes, they are more likely to maintain a high standard of care and avoid burnout and respond effectively to increasing demands in their work life. So organizational resilience ensures that frontline staff are not constantly working in a reactive mode, but instead are supported by systems that can anticipate and absorb and adapt to the pressure they are exposed to. This, again, we believe leads to improved mental well-being of the workforce. So enacting resilience, and as Axel told, resilience is not something that you just have. It's something that the system can perform. And it isn't just about recovering from strain. It's about learning and improving your organization through your experience. So we know that for patient safety and quality has for at least the 2 last decades been working on trying to improve healthcare systems by understanding the roughly 10% that goes wrong at any given time. Of course, none of us want anything to have any adverse events, but that is the risk of operating within healthcare. We know that something can go wrong. And even though the numbers are a bit different all over the world, and some say it is as much as 24%, roughly we can say that 10% of everything we do in healthcare have unwanted outcomes. But this also means that there actually is 90% of the things that we do that actually works. And we know that some units, some teams, some organizations works better and are more efficient in providing high quality care than others. So we have been trying to, over the last few years, to try to flip the coin and try to look at these 90%, because what is it that actually helps organization and unit to be able to provide care and high quality care at any given time in their organization. So this project that I'm going to talk a little bit about for you today is called Support for Resilience, Strengthening Resilience and Mental Wellbeing through the Support for Resilience Toolbox for Leaders. So as I said, we are mainly here in Europe, but I think it's not so different in India. And hopefully maybe you can also give us some feedback if this looks quite different for you. So in this project, we are 14 partners spread across Europe. We are divided by 9 different countries, and UIS and SHARE, the Center for Resilience in Healthcare, which I currently lead, is the project coordinator of this project. So I wanted to talk to you a little bit about how can we build organizational resilience. We have spent at least the last 4 years we had tried to identify what it is that contributes to resilience performance. What is it that these organizations do? And throughout the work, we have identified different capacities that is of importance for organizations to be able to lead with resilience performance. So among them are things as communication, risk awareness in the unit, competence, alignment between the organizations, coordinations, and these kinds of structures. What we also see is very important is the leaders, and the leaders play a crucial role and are essential for building the culture in an organization. And they can be the ones unlocking doors that leads to improvement, as well as being the one that stops improvement from happening. Many times, this is not to the fault of the leaders themselves, but that they are put in a very difficult position, the squeeze between overwhelming of tasks, and makes it difficult for them to actually help this. But we have tried to study what is it that the leaders can do something about that is actually quite important for the ability to operate in a resilient manner. We have done lots of reviews on this. We have done interviews, we have done observations, and we've tried to incorporate all this in a quite short amount of time for you to be able to postpone it. So what some of the leaders can do, and what is important for the individuals to also thrive in an organization, is that the leaders can foster learning and professional growth. So knowledge and continuous development is essential for strengthening organizational resilience, as they enable the staff and the leaders to recognize challenges quite early, to adapt effectively, and to learn from their experiences. A well-informed workforce is better equipped to manage complexity and can change without compromising quality or safety. So investing in learning builds the capacity needed to sustain performance and pressure and drive improvement over time. And we know that learning and professional growth might be things that we downplay and don't spend so much time on when we know that things are pressured. But on the other hand, we see that this is very important for the individuals to feel that they are invested in and important for the organization. Another important aspect is for leaders and for organization in general is to navigate the demands of work and life. So organizational and individual resilience are closely connected because resilience systems support resilience people and vice versa. So when workplace enables good work-life balance, they help staff to recover, adapt, and maintain their performance over time. So time and time again, a lot of, at least here in Norway and in Europe, they have called for healthcare persons to be more resilient. So they want the individuals to tackle more and handle more. So in our research, we are quite concerned that yes, we want the individuals to be robust, but the individuals are also dependent on an organization because these two support each other. And this means that the organization also needs to recognize what the individuals needs. So personal factors shape how individuals show up at work and in life, and this includes personal values, attitudes, health, family dynamics, and life circumstances. And showing as a leader that you know about then navigating the demands of work and life is quite important for the employees, because where the employees actually recover and build strength is within their relationships in their personal life and also in their at the workplace. The next thing we want to say something about is about balancing the management control and staff autonomy. So while control through clear structures is a key pillar of organizational resilience, resilience also requires room for flexibility and local adaptation when this is needed. So striking the right balance between management control and staff autonomy is essential for both leaders and employees to ensure the consistency delivering of high quality services. So structures are very important for resilience. They need to be in the ground because they create predictability and they provide clarity about roles and responsibility. And people need to know who is doing what in any given situation. So well-defined procedures and workflow supports consistency and coordination. So strong structures are therefore critical for maintaining a stability and performance, especially in high complex situations as healthcare. On the same time, we have to allow the staff the autonomy to use their professional ethos and to adapt to the local condition, because this fosters motivation and innovation and a particularly deeper professional engagement. So autonomy enabled through practices like job crafting and decision making with clear boundaries, of course, empowers employees to take initiative and actively contribute to improvement in the organization. So this in turn enhances the organizational overall capacity to adapt and thrive in changing environment. The next step is to have a shared understanding of professional expectations. One of the things we see that are highly reported as a lead to burnout is healthcare practitioner that has to leave their work not feeling that they were able to provide the care that they wanted to. So healthcare practitioners often strive to provide high quality care. They are driven by the desire to perform well and to ensure patient satisfaction. So actually to be able to go home from work not being able to fulfill this and the desire to perform well is quite draining for the individual. So many carries a tremendously high expectations of themselves, and this is rooted in also professional identity and ethical commitment and a desire to make a meaningful difference, which is very important to be a good caregiver. While this drive can fuel excellence, it can also become a source of strain, especially when expectations are unclear or resources are limited or priorities are competing. So leaders can actually help advocate for this, and one way of enhancing both organizational and individual resilience is to facilitate the creation of conditions that enable staff to perform their roles effectively and under clarifying what everyone is expected to do in their role so that we can have the same standards across the organization. The next thing is about building positive relationships. And this focuses on strengthening professional and personal relationships and interactions among team members in the unit. It emphasizes the importance of creating a supportive and inclusive culture where everyone feels valued and respected. So these relationships and interactions are significantly influenced by how a healthcare team functions. and it impacts the overall performance, effectiveness, unity, and the resilience of the team. So positive team relationships fosters collaboration and respect, while a weak work culture with poor relationships can undermine trust and mutual engagement. And particularly in high peak activity situation, this can lead to poor outcomes. So understanding and managing relationship dynamics is crucial to building well-functioning and resilient healthcare teams. Last up is the facilitating collaboration and communication. As we know, effective communication and collaboration are crucial for building a robust culture in healthcare because information is often key. So in fast-paced clinical environments, these elements are essential for patient safety, staff well-being, and also the organizational adaptability. So the belief that one can express oneself without the fear of negative consequences, for example, is vital for effective teamwork, and leaders play a key role in fostering this environment by practicing inclusive leadership and involving staff in decision-making processes. It is important to say that the leader is not the only one that can do something about these. All the things that I have addressed today is actually something that all of the organization can have as responsibility for. So facilitating open dialogues, encouraging reflection, and creating spaces for sharing experiences, and leaders can help staff learn from each other and take ownership of their work. So I said previously that it's important to learn from and understand what is actually functioning in our organization, but learning from positive events is actually quite difficult. So we have been doing this now almost 8-10 years, and I have been traveling all over the world and actually even talked to some of you guys previously at the ISQua conference about what is it that you're good at. And we're actually not so good at talking about that because I don't think we are not trained to do it. And particularly in patient safety, we have for such a long time focused on what we're not good at, which is also important. But we haven't learned to understand and analyze and reflect over what it is actually our strengths. So we need to have help kind of to understand what it is we do that is positive for the organization, why this is actually positive and who it influences and why, and then how we can use this to improve our services even further. So one of the things that we have done and worked on is to create a learning tool that can help focus on what we're actually good at and strengthening our organizational resilience to reflect over what we do well. And when I say things that goes well, it's not about excellent performance, but it is what is it that is work as done, as Axel talked about. What is it that actually works and functions in our everyday work? So we have an open available web page which I've been a huge part of, which have 3 different elements to it. So it has a mapping element, it has resilience scenarios, and has a resilience reflection list. And the aim of the first section, which is mapping, is to create awareness of areas of your team or unit's capacity for resilience. So how does it look like now? And here you have the 10 different capacities, and you can score yourself or your team on 30 different statements. And it helps you say something about where do you perform the best, because we actually want you to show and see what are we good at. And then when you said something that which elements you are good at, we also give you the overview of what you're not so good at. Then we want you to go further to the scenarios where the aim is to understand what your team does that actually provide positive outcomes, because it's surprisingly seldom that we actually talk about what it is that we do. And to put this into words and say something about what is it that you do that actually helps me in my work, we have a surprisingly little awareness about. So the scenarios are basically just a bunch of very short 1 to 2 minute videos about everyday things as medication administration or newly employed staff, where we want you to look at the scenarios and reflect over very short questions. The last thing is the resilience reflection list, which is aims to enable reflections during everyday practice. And it just wants to kind of switch the way we're thinking and how people think what went well and why in this situation, and maybe how did the different resilience capacities contribute. Was it the structure? Was it how we learned? Was it our coordination or leadership? Because if we can put it into words, it's easier to improve other parts of work. So if you want to check out the tool or our center and our work, you're happy to use this QR code. And that's me. Thank you.
Oh, thank you very much, Dr. Cecilia, for your wonderful talk. It's really great to hear from you. I was an authority in resilience, as far as I could say. I've just gone through your some of your studies. It's very, very nice. And of course, adapting these things in our country is going to be really an Herculean task. We need a lot of resilience for that. So it's great, great work. And I think I'm open for question and answer sessions. And anybody who's coming out, Sir, Professor Vijay Agarwal, sir.
No, it's a fantastic topic. And I think in India, you will have plenty of material, I think, to talk about, because I think as a country, and whenever you are working in a resource constrained setting, resilience becomes a automatic mode of survival.
True.
So, and I think that we need to kind of capture some of those moments that we use in our setups. For example, I remember that when I was the CEO of a hospital, and we realized that the care for the patients during the night is extremely risky. So the majority of the hospitals, I say, work on solar power. So their patients are at risk. And therefore, we used to say that before the evening, I wanted a list of the patients who are clinically unstable or emotionally unstable or financially unstable, or, so if that list is there with the top management, then we had the night manager or somebody putting an extra attention and to work on at least to try and reduce. So I'm just saying that I think this is a very, very interesting topic. And as Dr. Pichubani said, and we feel that both of you have stimulated our mind very much, and probably will get in touch with you during ISQua conference also to see that how can we take this more as a form of a study, and I'm sure that we can learn a lot. And there are huge number of people who are sitting here in this particular webinar of yours. They will all be, I think, very, very happy to contribute to this. So
there's a question. Thank you very much, sir. There's a question. Question answer box.
No, it's more a comment, and I would like to say thank you to Dr. Agarwal, because I think your notion is very important. Most development work and studies on resilient healthcare is performed in very well developed and rich countries. And of course, India is a rich country in many ways as well, but you have your sort of problems and with the situation in the countries. I think that the knowledge about patient safety and resilience would very much improve generally if we could inspire you to develop resilience in India and also do research on that. That would be very, very, very good, I would say. So I hope that we have inspired you in some way.
Actually, there's a question answer in the box. We have got a question called what type and level of relationship between the resilience and safety culture in healthcare organizations? Please comment.
Axel, do you want to?
No, you can.
So the question was the link between resilience and Dr. Pichwami, could you say the question again? Is it the one in the chat?
And level of relationship between the resilience and safety culture in healthcare organizations. Please comment.
Yeah, absolutely. It's highly a relationship between resilience and safety culture, because it is something about how you talk about. So in one of the 10 capacities we have is risk awareness. So actually how you think about risk, how you perceive risk, how it is the organizational talk about this is quite interesting from the resilient perspective. And it has something to do how you engage in this matter and how you are attentive and aware of what's happening in your organization. So the relationship between them is quite vital, yes.
Actually, one more doubt. How do you actually develop a climate change resilient organization?
Climate
How do
change.
you- Climate change, yeah.
Oh, I like that question a lot. We are not really there yet. We are having an upcoming conference or meeting in Brazil in October, where we will discuss climate change and resilience. That's a very good question. I hope that we can come back to that later.
Hope I'll be there to meet you, sir. We are coming over to Brazil along with Vijay Agarwal, sir.
Oh, that's good.
Good.
Thank you very much, sir.
Yes. Yeah. So,
Any questions, sir?
no, I think it has been a wonderful session, and we will be very happy to hand over our certificates of appreciation to
Thank you.
Professor Axel Ross.
I'm honored.
And
thank you.
yes, thank you so much, and also to
Cecilie.
Thank you.
Cecilie.
Oh, thank you.
Yes. And
thank you so
so
much for
thank you very
inviting us.
much, and you will be definitely receiving it, and our heartfelt gratitude to you. And to also say that the next month, the next first Tuesday, we are going to have the 58th webinar. I think we are really proud. We are just going to be almost 5 years of this association between CAHO and ISQua, and the speaker is Tiberius Pereira, and the topic is patients for patient safety. And again, another very important area where CAHO has been working relentlessly, and we had started a Patients for Patient Safety initiative, and that has now become a Patients for Patient Safety Foundation. So I'm sure that this will be a very, very interesting session. So next, this also, is the CAHO monthly quality meeting. We have now made the first Tuesday of the month that you people come and speak, the ISQua experts come and speak. A lot of hospitals in our country are now celebrating it as the monthly quality meeting, and therefore the whole program is being telecast there with a lot of people being there. Yes, so as you can see, we have the Vijaya Medical Educational Trust in Chennai, Mehta Hospital Chennai, Ganga Medical Center Coimbatore, Medica Super Speciality Kolkata, Fortis Punjab, Rajgiri in Kerala, Baby Memorial Kozhikode Kerala, Bethany Hospital Shillong Meghalaya, Sriranga Hospital Chengalpattu Tamil Nadu, and AJ Hospital Bangalore, Bombay Hospital Mumbai, Nirmalai Hospital Chennai, Jabalpur Hospital in Madhya Pradesh, Christian Medical College Vellore, Christian Medical College Raniput Campus, Institute of Neurosciences Kolkata, and Tata Steel Medical Hospital, Nazareth Hospital Shillong, Sehgal Hospital New Delhi, and ILS Hospital Damdam Kolkata. So you see, from the length and breadth of the country, this message is being given. And so thank you so much. We also have the upcoming activities and events that we would like to just share, and that is the on the 11th September, we have a virtual program and meeting on the 5S. On 13th September, on the one-day clinical communication program for doctors. And on 13th September, again, we have the hospital infection control practices program, training programs. On 19th September, we have quality tools and techniques. 20th September, we have migration from the ISO 15189, 2012 to 2022. And then we have on 27th September, nursing maths. So a lot of training programs. 28th September, we have a certification program on Bean Healthcare, improving quality and efficiency. And then 28th September, again on digital health standards. 20th September, we have on-site training programs, which is at Shifa Hospital in Bangalore, and on 27th at Ganga Hospital in Coimbatore. And we have a masterclass series, which will be on empowering clinical excellence, clinical indicators, and that will be on the 5th of September on nuclear medicine, radiology, and radiotherapy. Next, yeah. So the CAHO National Certifying Examination for Infection Control Professionals, the examination date is now 13th of September 2025. We have webinars and the clinical application of a robotic rehabilitation device for the hand and fingers, which is on the 5th of September. It is by the Global Rehab Forum. Then we have on the biomedical equipment webinar series, Principles of Radiation Safety in Workplace. Next. This is on 12th of September. Is that the end? No, there is a continuous our diagnostic education series on bone marrow interpretation, on One Health strategy to control leptospirosis, learning together India-Nepal health talks, laboratory testing in myeloma, next generation sequencing in clinical biochemistry. Then we have the Qualtech Healthcare program, which is for the team excellence in continual quality improvement. And the call for projects is already on. And this is going to take place on 13th of December. But the call that the people can present their programs for showing continuous quality improvement is there. Then we have endoscopy safety and facilitation evaluation EndoSafe program is again on. This is in collaboration with our industry partner ASP, and the registration is again already on of the EndoSafe program. Next. Then we have the infection control and antimicrobial stewardship compliance. I comply again with our industry partner Diversey and SafeCare, and the registration is already on. Thank you. Our events, which are SACON, which is our annual conference for the hospital administration students, and this is on the 19th and 20th of September in Hyderabad. This is in association with, I think, the Apollo institution. Right, next. Then CAHO Tech is the, again, one of the signature event of CAHO, which is to bring technology and healthcare together. And this is at the Kalinga Institute of Industrial Technology at Bhubaneswar, Odisha on the 15th and 16th of November. And it is a very, very important conference. This is the 10th annual conference. And we also have on the 15th, the Pitch Fest, which is to showcase startups, show disruptive programs, and to show the healthcare institutions for any early adoption of technology. And the conference is on 16th. And then we have, of course, Diagnosticon that will happen on the 24th and 25th of January in Indore next year. And of course, it will next go on to CAHO-Con, our signature event on the 11th, 12th, and 13th of April in Chennai next year. So block your dates. And I'm sure that you will see that we have a plethora of programs, training programs, events, diagnostic education series and whatnot. Ladies and gentlemen, CAHO is no more an organization. It is like an academic institution. It is like a movement. And we invite you all to join this movement so that we can help hospitals to move beyond accreditation from being an accredited hospital to a high reliability organization. That journey is very important if we want to prevent avoidable harm in the hospitals. So thank you very much. And once again, our profuse thanks to Professor Axel Ross and Professor Cecilia and Dr. K.P. Pichumani for so nicely moderating this session. Thank you so much. Thank you.
Thank you, Martha. Thank you, CAHO. And thank you.
Thank you, CAHO.
Thank you.
Thank you.
Bye.
A new dawn, a new horizon of healthcare delivery and patience.